So my name is Jennifer Puleo. I'm a nurse practitioner from Tampa, Florida. I've been doing this work in plastic surgery since 2001. As a disclosure, I do train for Allergan, and I'm also training for aesthetic advancements. So when you ask for that item on the right, do you ask for an adhesive Band-Aid or an adhesive bandage, or do you ask for a Band-Aid? And if you sneeze, do you ask for a tissue or do you ask for a Kleenex? So the bottom line is that neurotoxins, congratulations to Allergan. They've captured 75% of the market share, and Botox has kind of become the accepted name for neurotoxin. And I'm going to try my best to say neurotoxin all throughout this lecture and be a good CME provider here. However, it seems like for most authorities that Botox becomes like the natural name for neurotoxin. So they've kind of captured that market. However, there are 3 neurotoxins, and they're not all Botox. They're separate neurotoxins, and that's the point of this lecture. But the other day I had a patient come in, and she said she was in for Botox, and at the initiation of her coming in, she said that her friend had just went somewhere and just got Dysport. And could I tell her, should she get Dysport? And I said, well, absolutely, we could do Dysport if you want to. And I went through my big, long scientific explanation about the difference between Botox and Dysport. And at the end of it, she says to me, oh, so they're Coke and Pepsi. So they're not Coke and Pepsi, as you'll see through the lecture, but there are 3 major neurotoxins right now. And I'm hoping, my point of this lecture is that when patients come in and ask you, which should they do, or oh, my friend got Xeomin at this other office, that you have the tools that you need to explain how the 3 of them differ. So why use a neurotoxin? Really, you're using neurotoxin for lines that are from repeated contraction. How many patients come in and ask you to put Botox in their parentheses, or they ask you to put fillers between their eyebrows? And quite frankly, a neurotoxin is the drug of choice to use between the eyebrows. It's not, a filler shouldn't be your first line of defense there. There's many doctors that won't even treat that area by risk as if they had an occlusion. And then obviously, any lines that are being caused from muscle contraction, you usually choose a neurotoxin. And a lot of patients are first trying creams and lotions, but obviously these 2 aren't mutually exclusive. One of the doctors years ago, he said to me, it's like a mattress and sheets. You can have awesome sheets, beautiful, 400 thread count sheets, but if you have a crappy mattress, you're not going to sleep well. So we want to work on the underlying structure, but we want to use a neurotoxin on the top to make sure that we're getting rid of eradicating lines that are being made from continual contraction. It's not an age thing, obviously. I don't know about your market. South Tampa is a funny market. There's a lot of young people. I think people would be surprised to come and sit in our waiting room. We've got a lot of people that are in their 30s, late 20s, early 40s that are coming to do neurotoxins, and they're obviously trying to prevent. And I think there's a lot of validity to that, to preventing a line that never will really occur. They're much easier to treat than people that come in the later stage of life and those lines are ingrained. And the wonderful thing about those patients is now they've developed this trust for you, and you're gonna be their provider as they get older. So there's nothing wrong with these young patients coming in. So how are we gonna clear up the confusion of all the aesthetic options on the market? And first of all, with neurotoxin, the definition of it, it's a purified protein. So it's not the actual bacteria that's injected into the skin. It's one of 8 serotypes of neurotoxins. So there's actually 8 types of neurotoxins, but most manufacturers, as far as Allergan and Galderma and Merz, choose neurotoxin type A. Why? Because it's the strongest and the longest lasting. So you can see here when patients are concerned about long-term side effects with using neurotoxins, back in the 1950s, they were first starting to use it for medicinal reasons. They were using it for blepharospasm or torticollis. So I always say with patients, if they're worried about long-term efficacy or safety with neurotoxins, you are using a drug that's actually been around since the 1950s, and here we are in 2015. With 65 years of data, you're going to start seeing some ill side effects if there are some. So at this point, I would say that all the neurotoxins on the market are fairly safe. In 2002, Allergan got approval for the glabella line. In 2004, it did the axillary hyperhidrosis. 2009 was Galderma did the Dysport, FDA approval for the glabella. In 2011, MERS got Xeomin approved for the FDA for the glabella. And then just 2 years ago, Allergan got FDA approval for lateral canthus lines with Botox. So how does a neurotoxin work? Basically, with all three, it works the same way. When injected through the skin into the muscle, it blocks the release of acetylcholine. And without acetylcholine, it cuts off SNAP25, and when SNAP25 is cut off, it can't release acetylcholine to make the muscle contract. But the good news and the bad news is once the SNAP25 is cut off, it always grows back. And so the patient, if they love it, unfortunately, in 3 or 4 months, it's going to wear off and they're going to have to get it again. But unfortunately, if they don't like it, in 3 or 4 months, they're going to go to exactly how they started, because that's just the longevity of any neurotoxin. Why are there so many on the market? The bottom line is the 3 major cosmetic companies are all coming out with their own brand of neurotoxin, and then there obviously is going to be more. So Allergan, what I did is I made family trees for each of them, because when I'm explaining this to patients, I think it's kind of easy to say, well, this is this family of products and this is this family of products. So obviously the matriarch in Allergan's family was Botox. That was their flagship product. And then they came out with hyaluronic acid, Juvederm, and then they came out with Voluma. So those are their 3 major products on their family tree. So 1989, Botox was introduced. In 2002, they had the FDA approval for the glabella. In 2004, axillary hyperhidrosis. And in 2013, FDA approval for the lateral canthus lines. Galderma's family tree started with Restylane. It was the grandma in their family tree. And then they came out with Perlane. Then they decided to come out with their own neurotoxin, which was Dysport. And its FDA approval was in 2009. I just want to go back there. And then now in the last couple years, they've came out with Restylane Silk, and then finally they came out with Restylane Lift. MERS, their flagship product was Radiesse, and then they came out with their other fine line filler, Bellatero, and then they came out with their neurotoxin, which in 2011 they got their FDA approval for glabella with Xeomin. So the one thing that all of these companies have in common is they all have indications for the glabella. So all 3 of the neurotoxins are only FDA approved to treat the glabella, with the exception of Allergan went for FDA approval to also treat the crow's feet. But as we know with this drug as well as many others, there's lots of off-label places that you can use any of the neurotoxins. So with off-label use, we're having nasal tip elevation, we're injecting the mental crease into the mentalis, we're also treating for vertical lip lines. You saw that on the demos this morning. There's lots of other places to put neurotoxins. And some of these areas that you can put neurotoxins, the patients aren't aware of. They really still think of a neurotoxin as a forehead drug. So off-label use, I just listed a few of them, but you can do a lip augmentation, vertical neck banding, horizontal neck banding, bunny lines. So lots of other off-label usage for neurotoxin. And all that means is, when a patient's leaving your office, their amount of units that they're getting is getting higher, and so therefore that's just more reimbursement for you. So I don't want to read these to you, but I did put them in the PowerPoint because this is, it's not a how-to, but at least you could reference it if you wanted to in the future in terms of how to do each of them. But onabotulinum toxin type A is the generic name for Botox, and Botox, of course, is the trade name. And when they went for the FDA approval, they had 20 units in glabella. So all of these charts that I wrote for you come straight from the manufacturers, and they're showing you, of course, Dysport is abobotulinum toxin type A. They're showing you exactly where to inject. But what I challenge you with is this is the cookie cutter way to do it. But are you looking at the glabella, and are you looking at if a patient is stronger in their corrugators or are they stronger in their procerus? Therefore, are you adjusting the dosage accordingly? How are you doing it differently from the person next to you? What syringes are you using? Which diluent are you using? What reconstitution are you using? Because I know at my office, oftentimes people will say, oh, it doesn't hurt with you. Well, why is that? Are you holding the muscle? Are you stretching the muscle? So each of them, there's a slide in each of these for how many units that you actually put into the area. And then abobotulinum toxin type A is Xeomin, and its dosage is very similar to what Botox is as far as 4 units in each of the lateral corrugator supercilli, the medial corrugator supercilli, the procerus, for a total of 20 units. The off-label uses for neurotoxins, as we discussed, is the frontalis, avicularis oculi, levae or labi. So all these have their different reasons that you're doing it. There are, as James said, there's some authorities that are trying right now to microneedle neurotoxins into the skin and see its effect. I know personally I've used a neurotoxin to treat a patient's rhinophyma on their nose. I treat quite a few 20-year-olds that seem to think that their acne on their forehead gets better when they're injected with a neurotoxin. So you're seeing you're seeing a beautification of the skin as well as a calming down of the muscles. So there are some off-label things that are being looked into right now. I've tried in the pectoralis every which way but loose, and I've never had really great results with that. So I think that that may be something else that we need to use on there. Each of them have their own way to formulate their manufacturing and formulation process. And which one is better? I don't know. I think if you talk to each of the reps, they all tell you that their way is better, but this is just a graph that indicates to you that they all are slightly different in their manufacturing. You can see Xeomin is kept at room temp, whereas the storage of Botox and Dysport is a refrigerator, or mostly refrigerator, and especially after reconstitution. So there are a couple warnings that come along with any neurotoxin, one of which is the black box warning. And the black box warning is really a therapeutic warning. And when they had patients that were being treated in therapeutic doses, which are high dosage, they did find that there was distant spread of Botox or any neurotoxin. But that you've never seen that with a cosmetic dose. So the black box warning is there. However, you've never seen it with a cosmetic dose. If it comes up in practice, it just doesn't happen with cosmetic dosing. The other warning is non-interchangeability. So 1 unit of Botox does not equal 1 unit of Dysport, does not equal 1 unit of Xeomin. And so that is the warning that the FDA says, because the products are different, you can't equate one to the other. And there's no fast, easy recipe for equating one to the other either. I know when Dysport first came out, there was some thoughts that, if you took 1 unit of Botox or Xeomin and it was equivalent to 2.5 or 3 units of Dysport, there's no dose equation one to the other. So the FDA and worldwide regulatory agencies have recommended non-interchangeability warnings. Why? Because these products has different stability, different unit potency, different immunogenicity, so you can't just compare one to the other. Your dosing pattern should be based on your experience with it, obviously, number one, the PI, and then second, your experience with it, what you're seeing when you're injecting the patients and how they actually are responding in unit per unit. These I'm going to skip through because those are kind of the how-to. But what you'll notice on this is the onset of onabotulinum toxin type A Botox. It says from the package insert, the onset is 24 to 48 hours. And results last up to 4 months. And I think a lot of the drug companies try to say, well, ours works faster, ours lasts longer. But to this point, their onsets are very similar. And for those of people in here that are new injectors, onset is different than how it's going to look. With patients, I always say it's like a flower blossoming. and the little bud is starting to bloom at day 24 to 48 hours, day 1, day 2. Really, I prep them all at day 3 because I don't want any phone calls. So day 3, the flower is starting to blossom, but at day 14, it's at full blossom. So if they need any adjustment, I ask them I'm happy to see them afterwards at 2 weeks. However, please reserve their judgment for 2 weeks. Botox has been approved in 78 countries. Vistabel is what they call Botox in the United Kingdom, and it's the #1 selling neurotoxin in the marketplace. The similarities between Botox and Dysport, they're both considered heavier because they have added proteins around the molecules, and proteins can be used for protection. And so some studies seem to indicate that proteins may have a role in improving the effect, increasing the duration, protecting the molecule. But on the other hand, when you talk about, and this is your how-to on Dysport, Dysport was FDA approved it was in the UK in 1991, and its onset is also 2 to 3 days and results up to 4 months. And then switching gears here, talking about Xeomin, what it doesn't have is the accessory proteins. So they call it a naked neurotoxin. And so they seem to indicate that with it being a naked neurotoxin, that you have less of a chance of an allergic reaction, although a chance of allergic reaction to a neurotoxin in general is very slim. But you will see allergic reactions to the diluent, and I have seen that in clinical practice a few times where people will be allergic to the diluent, but being allergic to the neurotoxin itself is very rare. But that's one of the things that Xeomin says is because it doesn't have any accessory proteins that there's less of a chance of allergic reaction. Now Xeomin, it said it's for medium first onset is 7 days post-injection and 3-month duration. So that was according to their website in that literature. So it's slightly different than what the Botox and Dysport said, but roundabout they all are fairly similar. And this I just already talked about, referred to as a naked molecule because it doesn't have the proteins and less chance of allergic reaction. And it also doesn't need to be refrigerated once you bring it in. So this is one of my pet peeves, is if a patient comes in and they say, whatever, Xeomin doesn't work on me anymore, so I want to try Dysport. Or, I've been doing Botox for years, but it just doesn't seem to work on me, so I want to try one of the others. Well, I never believed that there was such thing as a neurotoxin not working on you. I always thought it was A, either they weren't given the right dose, B, it wasn't injected in the right muscles. I just never believed that there could be somebody that was immune to a neurotoxin. Well, I actually have my first patient, and guess what? I've tried all the neurotoxins on him. Every time that a new one comes out, I say, he's a doctor. I was like, come on over, let's try this one on you. And when I treat him, I put 100 units of Xeomin on one side of his forehead, just to see if I can see anything of it. And he has no response to it. And he wasn't even an abusive patient. He did 60 units every 4 months, but for some reason he has developed an immunity to a neurotoxin. So to dispel this myth, if one neurotoxin doesn't work, they all are serotype A neurotoxins. It is my understanding that none of them will work. So I just think that confusion needs cleared up with patients, because if you're letting them believe that this one doesn't work, so we'll switch to this one, maybe they'll like another one better because the way it kind of looks on them. But if one doesn't work, more than likely none of them are going to work on them. So why would you use one over the other? First of all, maybe person's anatomy. The research is back and forth on whether one of them spreads more than the other. I know that I originally thought maybe Dysport spread more on women with really large anatomy, or guys. I tend to think that Dysport turns out real pretty on them. So you may look at somebody's anatomy and feel like they would respond better to one neurotoxin than the other. And then the other reason is possibly financial incentives for the patient. They all have their little rebates or Brilliant Rewards or Aspire. Galderma has Aspire. So those are all little incentives to have one patient try one over the other. And then obviously marketing, whoever's going to deliver the most consumer marketing will usually win out there. And then when I talk about dispersion, Really your question should be is, will dispersion benefit an outcome or not? And I kind of, for those of you that were around this morning, I kind of talked about that a little bit when injecting. You can make your own dispersion. You guys are smart enough to figure that one out. And back years ago at a lecture, they were talking about kind of the visual effect of dispersion. And they said, I don't know if this is 100% true, but if you're using a 4 cc dilution, from the point of injection, the neurotoxin will spread about the size of a quarter. And with a 2 cc dilution, from the point of injection, neurotoxin spreads about the size of a dime. And then with a 1 cc dilution, it'll spread about the size of a pencil eraser. So that's the reason why for axillary hyperhidrosis, they want you to use a 4 or a 5 cc dilution, because you want to have more quarters to cover more surface area. So if you are using a product and maybe the patient puts the brakes on you because they only have so much money to spend, you can increase the dispersion either by, obviously, you increase the dose, you increase the dispersion, or you can add a little bit more saline to try to get it to spread a little bit more. But then there's obviously other muscles that you definitely don't want dispersion because you don't want to cause any ill side effects. New neurotoxins on the horizon. There's a company called Alphion, which is comprised of several of the people that left Allergan, and they're coming out with a new neurotoxin called Evisol. Just if you hear about it, that's one that is being studied and they'll probably come out with. New indications in the future. This is kind of funny. They're actually in stage 2, I believe, clinical trial studying the treatment of Botox with depression. And, you know, this slide is funny. It says, picture this, your appointment with your therapist is coming to a close, and instead of writing you a prescription for an antidepressant, they instead inject you with Botox. So it's questionable whether it's a physiological effect or whether it's a psychological effect. Is it that you look better and you feel better, and when you're walking down the street, you're actually looking more pleasant, so the person walking by you smiles at you instead of looks at you like you look frowny and miserable? And so therefore that whole cycle starts working where you feel better and you're getting smiles and you're given smiles? Or is it that the brain is actually being sent signals by virtue of the look on your face? If the look on your face is sending signals to your brain telling me your state of mind or state of emotion, it's debatable which is the case, but anyhow, they are finding in several pilot studies, in a pilot study, that 9 out of 10 depressed patients' symptoms actually improved when they are injected with Botox. So that's kind of interesting, and it's really interesting to think about with patients in general. If they look better, they usually feel better. So the bottom line with any neurotoxin is, you know, we all need proper training, so these aren't the outcomes that we're striving for. We're looking for a natural look. And in practice, I jokingly say to patients that this is all free for me, and I could put as much in as I want, but I choose not to look like that, and that's my same goal for you. So with proper training, you learn the drug's nuances, as well as learning to do it well. I encourage you to take every opportunity that you can to have more training. You know, for me, at this point, doing a neurotoxin is like breathing. I feel like I can do it with my eyes closed, but with any of the neurotoxins, you just get comfortable with it, and then you can almost experiment with different areas for it. We continue to build the reputation as practitioners if we have good outcomes and natural-looking outcomes with patients, so that's what we're striving for. And I thank you for your attention. This is actually my practice and in Tampa with my friends that work with me, and I welcome any questions. She asked if I have any experience with myoblock B for resistant patients, and I will tell you with this physician that is unfortunately immune to Botox, Botox, Dysport, and Xeomin, not just Botox. So I contacted medical research and asked what can I do with him, and they said that really the only suggestion they had is for me to do the myoblock. And then I looked at it and I saw how many units was in the bottle, and I thought, oh, I've got to learn something new and do that math. And so I just, so I have not tried that, but that was their suggestion. So if you ever came across that and you want to take the risk of, I hate learning new things, so that would be, yeah.
Jen, with your rapid metabolizers, so that we're not over-treating them.
Say it one more time.
With rapid metabolizers, I have a couple of clients that in
Yeah.
8 weeks, they're done.
Yeah.
They've run through it.
Yeah.
Without over-treating them, is there anything that you've found clinically that really helps with longevity in those clients?
No, but I do, thank you for your question. I have the same experience, and I have the same patients that come in 8 weeks and look, it's gone. So I do talk a lot about dosage, and I include dosage as a lot of my context when I'm talking to them, because the dosage is directly equivalent to the duration. So therefore, I don't know about you, but the most common place that I hear that it wore off too quickly is like the frontalis, okay? So I can treat your frontalis so it is rock solid, but the side effect of that is your brow is going to be heavy. And so I talk about this is what's recommended dosage for your neurotoxin, and this is what I'm doing. And at our office, you pay per unit. So unfortunately, I don't have any tricks for fast metabolizers. I know that it is a case that many people have that, and I don't have any solutions for it, but I will tell you that I talk a lot about dosing with patients, and they seem to understand it. Any other questions? Okay.
It's more of a comment. When Discord first came out, I remember we were kind of informed that there were more receptive sites that it actually works on than with Botox, and therefore the patient might have a longer effect, and those that have developed an immunity to, let's say, Botox, that said, oh, it's run out, that they might be better on Discord. And I actually have a few patients that in my 10 years of injecting Botox, and they've been really faithful.
Yeah.
They say, hey, this isn't working anymore, and we have had people get Discord.
That's great.
I was just wondering if you knew about the idea that there's more receptive sites. This was actually working.
I haven't heard that, but I do, in medicine, like anything's, and so when a patient comes in and says Botox doesn't work anymore and I want to try Dysport, and they do well on Dysport, good for them, because that's just the nature of medicine, is sometimes one thing works better than the other. It's just been, unfortunately, my experience that I try to, educate them that, oftentimes they'll say, this area worked, but this area didn't work. Well, two areas adjacent, one works, one doesn't. That doesn't mean you're immune to the neurotoxin. But that is an interesting point, and I'd probably have to do, I would like to do research on receptor sites, because I've not heard that, but that's an interesting point.
I think I told them, I heard it from our Scalera level. I think that's what
Well, it sounds good to me. Yeah. Yes. Yes.
I just wanted to share my experience. I always agreed that it was the same. It didn't matter whether it was Botox, Dysport, or Xeomin. And if they said, oh, it didn't work before someplace else and they came into me, I thought, well, the products are all the same. It really doesn't matter, until I had one.
Awesome.
Yeah, right? That one, right? Well, she came in and she said, I've tried Botox. It was from a very reputable place, and it really did not work. I got zero relaxation. I had full range of motion. And I said, okay, I believe you, but let's just try this other one, right?
Yeah.
So sure enough, I tried the Xeomin on her, and she did get relaxation, and I started with just a standard starting dose,
Yeah.
20 units into the corrugators. She did get relaxation. She had lack of range of motion afterwards. And then another time she came in, and we were talking a lot, and I was a little bit in a hurry, and I went for my automatic Botox instead of my Xeomin. And then I realized what I did. I said, uh-oh, I just used the Botox on you instead of the Xeomin. No charge. Let's do an experiment and see what happens here. And sure enough, it did not work. I had
Oh,
her
that's
come back
interesting.
specifically so I could check that range of motion.
Yeah.
So it was me, the same person doing
That's
it with
interesting.
the same muscles, and she really had no relaxation, full range of motion. So I've only seen it once.
Well, you know what? And I've only seen the immunity thing once, and I thank you for sharing that, because I have had patients come in and said, I went so-and-so place and the Botox didn't work. And so then I retreat them with Botox, and lo and behold, the Botox works. And so I thought that's where you were going with that story, but the story actually ended up wonderful, and I thank you for sharing that. Any other questions? Time is up in 19 seconds. We are good to go. Yes?
I was just going to say that you always, if someone comes in and they say that Botox doesn't work, you also, since you didn't do it, you didn't reconstitute it.
That's right.
You have to think about what could it have been left at room temperature for too long.
That's right.
Alcohol.
That's right.
In there with a clean laptop and then injected the saline.
That's right.
Deactivate the Botox.
That's right.
So
Well,
you're it yourself.
that's right. And that's where I thought she was going. Because I've had, but anyhow, I totally agree with you. So you just can't buy everything they're telling you. Well, thank you again for your attention, and have a good afternoon.